So welcome, Dr. Ridley. Welcome to Torn. I've been waiting a long time for this to kind of get this started, so welcome. Just to start off, kind of introduce yourself and a little bit of your background.
Yeah, so I'm Dr. TJ Ridley. I'm with Twin Cities Orthopedics, working with you. I'm from the Midwest originally, born and raised in Minnesota, did my training around the Midwest, and then did a sports medicine fellowship at the Stedman Clinic in Vail. And so, certainly I have a sports medicine focus within my practice, really focusing on athletes of all kind that just want to get better and get back to sport. And obviously with that, the most common injury and surgery that I see and do is the ACL.
Once that athlete goes down on the field, some sort of medical professional goes out there. They may check the knee. They may not. They may get the athlete off the field first. My next kind of transition point is once that athlete makes contact with you, what's that initial conversation look like? And kind of talk me through, the first steps of when you make initial contact with that athlete.
Yeah. So, first step when I see them initially is just kind of trying to build that rapport and trying to just figure out who they are and learn who they are. Are they, what level athlete are they? If they're in high school, do they have aspirations or plans to kind of play at the next level? If they're in college, what are they really looking to get out of this? And so just kind of trying to figure out who they are and what sports and multiple sports and that kind of thing. And then that can help me drive kind of some of my conversations later. Certainly for me with having x-ray right down the hall, they'll have an x-ray before they come in and see me. Mm-hmm. I'll talk with them. I'll examine them. Now, if they've been seen by another provider, one of our urgent cares, and they're already coming in with an MRI, certainly we may kind of jump more quickly to that. Sure. But a lot of times they're coming to see me for the first time. Yep. And so, we do the evaluation. I kind of express what my concerns might be considering their injury and what I feel in the exam, talk about, what the MRI looks like. Then I'll have them come back and see me to go over the MRI. And then once we have the MRI, I do like to pull it up on the screen. I like to kind of show them everything so they can kind of hear it and understand it. And then certainly we go into the conversation about, what does treatment of this look like? And ultimately it's a surgical type discussion.
Are you pushing an MRI no matter what? Or what's that conversation like as far as if you don't feel something, but, you've come across that before where if you feel it may potentially be or might not be, and then it turns out to be an ACL or something other than that. What's that conversation like? Or are you going to kind of, let's get an MRI no matter what? Yeah,
I'm very quick to get MRI on any young athlete who has an injury, whether I'm suspecting MCL or ACL or patellar dislocation. Yeah. When I first started, you kind of get out of training, you're kind of like taught like, okay, be judicious about the MRI stuff and make them fail kind of the conservative treatment. But then, maybe it's because some of it's with my fellowship training when we see so many athletes and you just see this injury so many times that we're very quick to get an MRI, out there in Vail. And I think I've just kind of carried that with me because if you get an MRI and it's negative, great. Everybody's happy. If you don't get the MRI and they don't do well and they have another injury, now you're really risking more injury to the knee. And then of course, things just don't go well. So I'm much quicker to get an MRI. Even if I have a lower suspicion that something's injured, again, some of this is building that rapport and feeling out with the patient, that kind of thing. And oftentimes it's mom or dad or whoever they're with. But for me, I like to get that MRI because even if I have a lower suspicion that, maybe it's a contusion or something like that, at least then I can show them on the MRI, hey, things look really good. We can return you back to sport when you start feeling better. We don't have to be worried about healing and that kind of stuff. Or maybe it is a grade 2 MCL. Then we can sort of classify that and I can lay out the expectations for them. Yeah. But certainly when there's a cutting movement, a pop, any swelling or any effusion in the knee, any limitation in range of motion, it's at least a recommendation of MRI. It's of course their choice to follow it, but I recommend the MRI very quickly for a young athlete who has a cut, pop, pivot type feeling in their knee.
I appreciate that. I think there's some aspect of it to it is where, if someone's not maybe referred to you and they're referred to, I don't know, a general practitioner or maybe someone who hasn't dealt with knees before, that if they don't suspect pathology in the knee, that they may say something that borderline triggers the athlete that they're fine. So I think what you're saying is building that rapport in the conversation with the athlete of, we're just going to check this. I may not be feeling something, but I want to make sure we go down every route before it's, you're going to be fine to go back to sport. Because I've come across this before from, patients who I've seen down the road who have said, or even just, in passing where, I initially got injured. They said my knee was fine. I went back out. And then 3 or 4 weeks later, I actually felt something that was, very difficult to get back from. So that conversation, I think, is fairly important too. Fair enough.
Yeah. Oh yeah, for sure.
Yeah.
I mean, I think, and you've probably seen it too, where somebody even has like a little bit of an injury. They start feeling fine a couple of days later, and then they go back to sport and then they have another injury. I had a patient 2 weeks ago, bigger lineman. They're starting kind of their summer and into this fall training stuff. Had a little bit of kind of a didn't feel right movement in his knee. They came in and saw me. He's so big that I had trouble even getting like a real exam on him. And, he's a little bit limited. He's kind of describing the movement he was in when he felt it. And I just said, you know what? Just to be on the safe side of things, let's get an MRI to make sure it looks okay. Like, I got a trip next week to go do some college visits. Can I go on that trip? And I said, well, go do some walkthroughs and stuff, but until we have the MRI, let's make sure. Well, sure enough, the MRI comes back and he's got a complete tear of the ACL. He's got a bad meniscus injury. He's even got an osteochondral defect, like big bad injury.
Sure.
And when I told him, he was so surprised because he's like, I've been feeling better and better each day.
Yeah.
Like, well, unfortunately, sometimes that happens, but the MRI is not lying here. You really did some damage to this knee, and we really need to take care of those.
Sure. Yeah, I think the presentation versus what the MRI shows can be drastically different.
Totally.
So talk me through. So we have had the MRI that's been confirmed with an ACL. The athlete goes back in and has that conversation with you. Talk me through like the next stages of, you've kind of built that rapport as far as, are they a level 1 athlete? What do they want to get back to doing? Talk through graft choice and maybe, so first talk about graft choice. And then my next question would be, let's say an athlete says maybe they don't want to play sports again. What's that conversation like if you would ever say, okay, I'm on the same page of you if you want to try a conservative route?
Yeah. Or how about this? I'll kind of give you kind of my spiel as if you're like my patient and you can kind of get kind of expert. Because I feel like we could go in and talk about graft choice for a long time, right? So maybe that'll segue us to the next part. But so, when we've confirmed the MRI, basically what I'll do, and I'll just kind of simulate like you're my patient, and then kind of just go through the spiel. So, the ACL is really an important structure to the knee. It certainly gives stability to the knee. And so anybody who wants to do any sense of cutting or pivoting or even like stairs or yard work and things like that, anybody who wants to be relatively active, you're going to want that stability in the knee, and the ACL provides that stability. Mm-hmm. Unfortunately, then a knee that's unstable is also at risk of more injury to the knee, particularly the meniscus and the cartilage. So not only is the ACL important as a stabilizer of the knee to help you do those functional activities, it's also protecting the knee, protecting it from further damage. So for both of those reasons, it's really important to have your knee with a properly functioning ACL. Mm-hmm. Now, certainly there are some people who can accommodate and they can overcome this with the physical therapy. Maybe it's a brace, but we do find that those cutting, pivoting types of activities, do put you at risk of having more instability and risk of further damage to your knee. And so for all of those reasons and the activities that you're telling me that you want to return to, I certainly recommend surgery for this. Surgery for this is an arthroscopic procedure. And, similar to how the ACL doesn't have the ability to heal itself, it also doesn't have a great ability to be repaired or sewn back together. Yeah. And so what we do is we reconstruct the ACL, or in other words, we replace your ACL, kind of get rid of the old and in with the new. Yeah. And with that, we have to get you new tissue from somewhere. And there's two main places that we get that from: cadaver tissue and your own tissue. Mm-hmm. And this is where then I'll kind of decipher in, depending on who the patient's and their age. Let's say they're a younger athlete. Totally. At your age, I would definitely recommend we use your own tissue. It's healthier, it's more reliable, and study after study has shown that there are better results. There's lower re-injury or re-tear rates by using your own tissue. Mm-hmm. So we should definitely lean towards using your own tissue. Now, maybe if the patient's a little bit older, or maybe they're not quite as active cutting, pivoting, then I'll talk, okay, the allograft, the donor, the cadaver graft is a reasonable option. There maybe is a slightly higher re-injury rate with that, but we don't have to steal it from anywhere on your own knee. Sure. So there's maybe some less pain, some less morbidity from that, maybe a little bit faster turnaround from pain and kind of early mobility. Long run, long time, return to play and activities, things like that doesn't necessarily change. Mm-hmm. But using your own tissue is definitely a little bit more reliable, a little bit healthier, lower re-injury or re-tear rate. Mm-hmm. And when we talk about the tissue that we get from you, we're talking about basically these days in my practice, we're talking about two main options from that injured knee. And those two options are the patellar tendon, or the bone tendon bone, or the BTB as people call it, yep, or the quadriceps tendon. The third option that's still used very, very often, it's still used around the world and still a good graft choice, it's just fallen a little bit out of favor, is the hamstring. Yeah. But particularly we're talking about the patellar tendon and the quadriceps. And certainly there are pluses and minuses to that, of course, which I'll talk you through. Yep. But ultimately, when you really break it down, there's not a wrong choice. There's pros and cons. There's trade-offs of these different graft choices. And that's where we talk about it and kind of have a discussion. And ultimately we decide together what that's going to look like and what makes most sense for you.
Would you automatically go down the route of patellar tendon versus a quad, or kind of weigh the pros and cons if I'm, an 18-year-old asking you that question?
Yeah. I mean, I definitely give patients the talk, and I definitely lay both the options out and have that open discussion as much as possible. Yeah. Now, if they, oftentimes they'll say, "Oh, I don't know, doc, you tell me, you pick."
Sure.
I would say, yeah, in a young cutting, pivoting athlete, I still lean heavily towards the patellar tendon. I still think it's the gold standard. Yeah. I think all the studies that you look at, I think they're still trying, and they're always comparing to the BTB, whether that's quad or quad plus an LET or hamstring plus an LET. They're always kind of like using the BTB as the benchmark. Now, you could argue our benchmark is still maybe not where we want it to be, but I still think that the BTB is sort of the best that we have found from a re-injury, re-tear rate.
Yeah.
Obviously, the downside of the BTB can come with anterior knee pain in the front of the knee, maybe some patellar tendonitis, and particularly like kneeling pain. I don't know about you, what you see, but for me in my practice, I don't hear a lot of patients complaining about patellar tendonitis, patellar sensitivity. And a lot of them maybe aren't really kneeling directly on their knee to know, but I mean, I push and I try to tease it out because I kind of want to know. I don't find that the anterior knee pain stuff is maybe as much as maybe other people talk about, or historically. Maybe that's because now we, maybe pay more attention to it. I close that tendon down. I even save the peritoneum, this thin kind of membrane, and I close that over the top because it does have good blood supply and healing properties. I mean, I know in the past, they didn't even repair the tendon itself. Some people still don't. Some people still don't address the peritoneum. So I think taking all those extra steps, maybe that's why I don't experience as much of that knee pain stuff. But again, maybe you're not seeing as much either.
You know, at least for me, I start with isometrics, get their quad to load through that. And if they can tolerate a basic body weight knee extension, I'll just slowly load from there. And if you take that the right way, usually you don't come across a bunch of patellar tendon type stuff.
Sure.
So I think it's probably the combination of that. And then, you know, an appropriate progression to knee extension is generally, I don't see too much out of that. Talk me through. So, you know, let's say we've chosen a patellar tendon graft. Talk me through, you know, talk me through what we see in evidence, at least from your side of things, is like the optimal time frame from injury to surgery, you know, and then what are a couple of things you like to see objectively in the knee before, let's say, maybe you feel comfortable performing a surgery on a knee?
Yeah. I mean, I think the timing thing is still, controversial and debated. You know, right? Is it just do it as soon as possible, get them start recovering, get them moving?
Yeah.
Or do you got to wait till the knee cools off and get the range of motion, get the effusion out? I guess I'm kind of somewhere in the middle of the spectrum. Usually by the time they've seen me, you know, it's been a week or two since injury, or at least since when I get the MRI, right? Like maybe I saw them initially, but by the time they get their MRI, like it's been a week or two. So they've already kind of like settled in. Yep. If I see them right away, if I suspect it's MCL or ACL or what, no matter what, like I'll say while we're waiting for the MRI, let's get you into physical therapy. Perfect. Let's say worst case scenario, you've got an ACL tear and a bad meniscus tear.
Yep.
You're not going to do much harm by starting and initiating some of that physical therapy. We're going to jumpstart stuff. So let's get you in with physical therapy. We got to wait for insurance to approve and schedule the MRI or whatever it is. But like, let's get you going.
Yeah.
So usually by the time I see them for their MRI review, their knee is almost like ready to go.
Sure.
And then by the time you get scheduling, you know, maybe it's another 5 to 7 days or whatever it is. Now, side note, maybe talk about later, bucket handle meniscus, maybe different story on timeline of things. And that will definitely push me to a more urgent time frame surgery wise. But otherwise, yeah, I'll as long as their knee is relatively quiet, they've got some decent range of motion, then I'll proceed. Now, if they're really apprehensive, if they've got a really big effusion, 15 degrees of extension and only 90 degrees, okay, I'll let it cool off another week or two, kind of monitor. But I'm kind of done away with we should wait till your knee has full range of motion and your knee is totally quiet, because it's kind of like if after 3-4 weeks it's not quiet, I don't think waiting another 5, 6 or however long to let it calm down is going to make a difference. It kind of, at that point to me, is what it is. Let's go get this thing moving, get it washed out, get all that fluid and blood out of there, and let's just get going.
A little bit of a broader question, but talk me through kind of the basic steps of, you know, in the operation room. So someone's coming in, you know, it's an ACL. Let's say maybe the MRI is, you know, not completely conclusive on a meniscus. Obviously, most likely you're going to check the meniscus regardless, but talk me through kind of the steps of once that athlete is in the operating room, kind of how that works as far as graft prep, what you're going to look at meniscus wise, and kind of this generic kind of steps along the way.
The first step is the graft harvest. So if it's the BTB for me, it's BTB or quad, and 99%, you know, I'll do a hamstring if somebody basically really has a preference to it. Maybe the other side of the thing. But anyways, I'll do my graft harvest first. Then I'll do my diagnostic scope. So I get to stick the camera in, go through all the different compartments, all the nooks and crannies, you know, probe and feel the meniscus and the cartilage and all of that kind of stuff. And it's one where I definitely will probe everything. Some people maybe will just kind of peek in every corner. I think you definitely have to lift up the meniscus, push it down. Just had one today. Sneaky little tear underneath the meniscus when I lifted it up. If you look at the top surface, looks great. Lift it up, nice little tear there. So I think it's important to really do your thorough diagnostic exam. Once I then kind of have the lay of the land, then I can kind of like, tell the team, okay, this is what we got. We got ACL, we got the meniscus, we got a cartilage thing. We're going to have to microfracture, whatever it is. We just get all kind of instruments and everything kind of ready. So, then let's say there's no meniscus, don't need to worry about it, just ACL.
Yep.
So then my assistant will use, he'll be on the back table with the graft that we've just harvested, and he'll be preparing that and getting it to the right size and everything like that.
Yep.
The general concept of ACL is you create these tunnels in the tibia and femur through which you pass and then secure the ACL.
Sure.
So what I do is I drill a tunnel up into the tibia. And for me, that's a full tunnel. Mm-hmm. And that will be sized to the same what the graft is getting sized on the back table. Usually it's about 10 millimeters around.
Yep.
And then I'll drill a blind socket or an ended socket rather than a full through. It'll be drilled to a depth of 20 or 30 millimeters, something like that. Again, size to the graft, maybe 9 or 10 millimeters.
Yep.
So then when I bring the graft up, it comes up through the tibia and then gets dunked into the tunnel in the femur. And then because it's kind of got an end point, it kind of stops there.
Yep.
And then again, we can kind of go into more details. Depending on the graft type, there's different ways that you then fix the graft in place.
Sure.
So now you got the graft in the right spot. You like where everything is. Now you got to secure it in place and then with the right amount of tension. So when you're doing a bone, tendon, bone, a BTB, a patellar tendon, you got this nice bone plug. So what I'll do is I'll then insert a screw, an interference screw to kind of pinch that bone in the tunnel and secure it that way.
Sure.
When it's a quadriceps, there's no nice bone for that drill or for that screw to just like lock into. Yep. So what we do is we use a button. So the button will actually pass through that blind socket, go up, and then flip on the other side of the bone, and then it can resist back, and then you can kind of tension and pulley the thing up that way.
Yep.
So we've got everything in place, at least on the femur is where we secure it first. Yep. And then for me, I range the knee, and actually I cycle it through many times so that I get any sort of extra stretch or creep out of that graft and the collagen and all that kind of stuff. And then bring the knee into full extension, and I always secure it in full extension. I think there's been some good recent studies that have shown outcomes tend to be a little bit better when you fix it in full extension. Some people do it in like 15 degrees. I just think that I think you don't over tension the graft. I think when you do it at 15 or anything more than 0, I think you over tension the graft. It becomes too tight. And I think then that limits your extension, limits your range of motion. Maybe it over tensions and then stretches out the graft to the point where it's maybe not functioning like it should. It gets overstretched. So, that's my theory or thought behind it.
What would be the reason for, just so we're aware, why would you tunnel the femur first? Or why would you, fix the femur before the tibia? What's the reason for that?
Yeah, I mean, I think it's just kind of like ease of getting the graft into place. So, when you talk about ACL surgery, and you talk about the tunnels, there's kind of two different ways you can do your tunnels these days.
Yep.
One is the way I described, where you do a full tibial tunnel, and the other is what's called like an all-inside approach. So sure. Similarly, you have blind socket on the femur and the tibia.
Right.
And when you pass the graft up, for me, through the full tibial tunnel, then I can pass it all the way up, and then it hits that dead end, and then I can secure it in place. And then when I bring it into full extension, I can visually look and see,
gotcha.
That tibial tunnel, you can visually see it directly. The femur, you have to be inside with the scope and with the camera. And so, there's probably somebody out there who secures it first on the tibia. I've never seen it that way. Yeah. And so I think it's just the ease of the way you do it, the sequence, but it's probably something to do with, like arthroscopically, you got to be inside the knee for that femur, but you can be more or less outside the knee for that tibia fixation.
That makes sense. I think one of the other reasons why, and you can expand on this, why I like the patellar tendon, just because of the fact that it does have two bony blocks on each side. I think there's maybe something to be said about the security of that versus, a hamstring graft where you don't have either of those, and a quad tendon, you obviously have one, but not the other. So is there something to be said about that too, as far as security in the knee?
Yeah. I think for me, that's everything. I think The bone itself, we always talk about in orthopedics, like bone heals better to bone.
Yep.
Bone healing to soft tissue or soft tissue healing to bone doesn't heal as robustly. Think about like rotator cuff healing and even meniscus, like soft tissue healing. Bone just is so vascular and it just heals so well, like a broken bone. It just can heal really well and actually heals faster than soft tissue. So I think from the biologic standpoint, I think that's a big reason why the BTB to me is more robust, it's stronger, maybe has more reliable, faster healing. But then that interference fixation with the screws, I think to me is really nice because you have direct compression of the bone to the walls of that socket, right? And that bone is getting squished into bone and it's holding it there. There's no wiggle room.
Yep.
When you do suspensory fixation with the button, oftentimes, so you have the button, you got at least probably a 7 to 10 millimeter gap of like tissue, of suture,
yep.
And then you get to the tissue on the graft. So you get this span of suture before you get to the tunnel and the graft.
Sure.
And so you can get this windshield wiper effect.
Gotcha.
And while you try to size that soft tissue to the exact size of the tunnel so that the tissue kind of squeezes in there, there's fluid, that soft tissue can expand and contract depending on how much fluid's in the knee and fluid with the scope and blood and all that kind of stuff. So you're relying on this windshield wiper suspensory fixation. And so one thing you worry about, especially with hamstrings, it hasn't maybe been as much of an issue with quadriceps, maybe just because we haven't followed it long enough. But the tunnel dilation is a big issue when you talk about if a graft fails and you need to revise it. Now the tunnel has widened. That 10 millimeter socket that you drilled, all of a sudden 15 millimeters wide. And it's I think it's because that tissue's been windshield wipering and wearing out the bone around it, right? And so I think that's a big difference for me of why I love a BTB graft. And to me, it's still the gold standard. To me, it's still the way I lean kind of that young pivoting athlete. Again, nothing necessarily wrong with the quadriceps, but I think it's, it's these things you have to consider.
Yeah, I think that's a great point to kind of expand upon that surgically too. Cause, it's one thing rehab wise, security, but just that placement inside the knee itself, I think is important to talk about. Talk me through a little bit about some of the things that may arise in surgery that kind of give you, or some complications that may arise, whether it's, maybe there's a meniscus or, maybe the age of the athlete, or if they have a patellar tendon that's just not, maybe it's short or thick, or, maybe some of these other things. Just kind of expand upon some of the things that you might come across that throw maybe a little bit of a wrench into surgery.
Yeah. Yeah. I mean, of course, like complications can happen at every step of the way, right? And so you just have to be ready for all of them. And, but I'd say kind of like the more common, things that you run into. So one of the reasons why I love the BTP is that I can choose like the width and the size of that graft. And I can in a way choose how much bone I'm taking on either side.
Yeah.
The quadriceps, it definitely varies how thick it is, how far up or how proximal that tendon starts to where it ends.
Yeah.
And so for me, like the quadriceps can be a little bit less predictable of how big of a graft am I really going to get. And I think that's a big downside to the hamstring. That you really, whatever size hamstring they got, that's what they got.
Totally.
But the things you got to be watching out for on the BTB is certainly you can get fracture of the bone, right? So, you get fracture of the patella. Rarely you get fracture on the tibia, but it can happen. So, those are the things on the graft harvest side of things you got to just kind of watch out for. With the BTB, the way the incision is, you do have that sensory nerve branch that crosses there. So more often with the BTB compared to others, you can encounter that nerve and cut that nerve. So people will get that passive numbness on the outside part of that incision. But do your quadriceps, you still need to make a similar incision, so it's not as big, it's just lower down.
Sure.
You can still run the risk of running into some of that stuff, so people can still get that little patch of numbness. So you're not totally devoid of that. So, then when you get in with the camera, of course you can run in all sorts of meniscus stuff. And so you got to be really ready and facile to fix any type of meniscus you encounter. I mean, it's not just a one trick thing. Like, you can't just use an all inside. You can't just use these simple devices that they've come out to make it easier. You got to have the other sort of tools in your toolbox to do an inside out type of procedure, or you got to be ready for a root repair. So the thing that's, cautionary for people getting into practice, or, for patients when they're looking for where to go, like, although the ACL surgery is, it's a common surgery, it is a really technical surgery, but what's even more technical is the meniscus.
Sure.
And number one, recognizing it. As I mentioned, you got to look and feel and know where to look and know when to be suspicious of it, know when to fix something. So you got to recognize it, number one. And then you got to be able to address it, number two. And a lot of times, it's kind of the more generalist, or if they don't have as much training, particularly in the meniscus side of things, well, shoot, let's just cut and trim it out. Not much I can do here.
Yeah.
We certainly want to try to save that meniscus as much as possible. And so you got to be ready for all of those things. And that's where the complexity really starts to build.
And how quickly you have to kind of make those decisions.
Right. You got to be ready, and you got to kind of know then what your steps are going to be. So if you do a root repair, for example, you're going to drill through the tibia. Well, you got to be able to avoid that tunnel that you drilled for the ACL, right? Mm-hmm. You got to avoid those things. If you're going to do an inside out, you got to know your surgical approach and be good with the soft tissues, and you got to know the anatomy, and you got to have a good assistant. And so that's where the level of complexity all of a sudden starts to build. And, I always joke around with the surgery center, they'll book just for an ACL surgery. I always want them to at least put on possible meniscus, because it's about 10 to 15% of the time. Yeah. MRI doesn't show anything, but you get in there and the meniscus, something's going on with it. Whether that's just the MRI didn't pick it up, or it occurred between the time you waited for the MRI and the surgery and the this and the that. Sure. So you just got to always be ready for that.
What do you see as far as percentages? You're doing, like you said, an ACL. You're obviously thinking in the back of your head, I'm going to check the meniscus. And, what's that percentage of the number of times that there probably is something going on with the meniscus?
Yeah. I'd say probably overall, like with and without the MRI catching it, I'm probably doing an ACL plus meniscus 40 to 50% of the time. And not a lot of that, right? The MRI caught ahead of time, but there's definitely, again, like that 10 to 15% where I get in, I wasn't planning to do any meniscus stuff, but it happened. Yeah. Or like it's there and we need to address it. So it's common for sure.
So talk me through this. So, you've done the surgery. Talk me through what's the, time frame in which you want to start rehab. And then from there, kind of more or less, talk me through like your communication or your relationships with the physical therapist that you work with, and like what does a physical therapist have to have, or the communication or relationship that you guys have to have that makes the rehab seamless, or at least as seamless as possible, so that the athlete can get back as fast as they can?
Yeah. I mean, for me, like number one, like I try to get the rehab in early and often. So oftentimes we're getting them in post-op day one.
Sure.
And, I tell patients are always maybe a little bit weary about going in right away. I mean, I tell people it's more mental therapy than physical therapy those first 1 or 2 sessions. But I think it's so important to have somebody kind of go over everything, just kind of glance at things, look at the brace, make sure it's fitting, make sure the ACE wrap is still fitting, answer questions, and kind of lay things out and start some range of motion, give some guidance on the brace. Because,
sure.
Although I work with kind of the same, nursing crew for, going through all the post-op instructions and things like that. And they do a good job of kind of telling them, talking them through. Inevitably, it's going in one ear out the other, because they're so overwhelmed, because they're looking at their family member, like, half with it on the recovery, in the recovery room. So it's so good to have that refresher the next day or 2 days later, whatever, just have somebody just kind of to talk through it all. Yep. And I think it's good to just have that education. Okay, this is what we're going to do. This is what we're going to expect. This is what's okay to do. This is what's not okay to do. And more or less, it gives people the confidence. Oh, I can move this? I didn't think I could move it. I thought I was supposed to lock the brace the whole time. It's like, no.
Yeah.
Like, let's get moving here.
Yep.
So I like the early and often. I do use a brace. There's definitely literature out there that doesn't maybe necessarily support the use of a brace, but I like it just from a patient sort of like, anxiety, just give them some confidence.
Yeah.
I do like the fact that you can lock it out straight. I do think there's some benefit to locking that knee out straight, at least at night when they're sleeping.
Me too.
Because I always tell people, phase 1, extension. Phase 2, flexion. Like, get that thing in almost hyperextension at night, or, get that thing straight at night, lock it out. And then maybe mobility, they can lock it. I just think it gives some added benefits.
Yeah.
And again, maybe the literature doesn't support the long-term sort of benefits. But from a patient satisfaction, I think if you ask them that 2 weeks and 6 weeks, did you, if you randomize a no brace, a brace, I think most patients say they like the brace, at least for that security blanket. After 6 weeks, yeah, they want to get rid of it. I don't blame them.
Okay.
And that's what we do. We have them get rid of it 6 weeks. But I think then for me, the next component is that open communication, or that clear communication with the therapist of, okay, what are we doing here? Because sure, like, ACL, range of motion, weight bearing, taller, right? Mm-hmm. But the big question is, okay, well, did you need to do anything with the meniscus? What's the weight bearing status then? And for me, I have different protocols depending on what type of meniscus tear there was and repair and all that kind of stuff. So I think it's really important. I mean, for me, I put in all my operative reports at the end, I put in which protocol we're doing and that kind of stuff. And so, you guys in our therapy department, they know to look there. But of course, when I do therapy the next day, that note's not in usually. I haven't signed off in the dictation report or whatever yet. So I think, our therapy group has done a good job of reaching out to me like, hey, I got so-and-so coming up in an hour or later today. What happened? Did you end up doing a meniscus? Did you end up doing XYZ? And then, it's on me then to have that clear communication of, nope, no meniscus, free to do the ACL, or like, this is the protocol we're doing, or, hey, actually, like, it was this type of tear, but it was a little bit tenuous. I want to go slow, right? Like, it's not a one size all fits all, one size fits all for all this. So I think that communication is so important. And so if you're a therapist, I think it's important to establish that with your provider. I think if you're a provider and you don't like getting emails and phone calls, getting bugged about that stuff, I think you got to change that around, because I think it's so important that everybody's on the same page. And I think that goes for when you're having that 7 month and that 9 month discussion of, okay, where are they at sport wise? Are we going to start the return to play? Same thing. I think you've got to have that relationship with your therapist and with your surgeon back and forth to have that communication of where are we at.
Yeah, that was going to be my next question is, I think at least from my standpoint, the importance probably, initially of like, if there's meniscus pathology, how do we figure this out communication wise? Throughout, obviously, we hit different time points of, strength testing, hop testing, all of these things. That I think is obviously fairly important when you check in with, an athlete at, let's say 3 and 6 months, that you want to have some of that objective data to kind of go back on. And, if you have anything to say about that, you can at that point with that backup that you have. I think probably at least that I've come across is one of the most important things is the communication of getting back to return to sport, or at least initiating, some sort of return to sport timeline. There's a lot of evidence out there as far as objective data and solely going off of objective data. I think at least in my practice, that's important, but it's not the only piece. And we've talked about this before too, is the subjectivity of how an athlete looks is also important. And I think that's where, hearing your side of things when someone is actually like fully returning to sport, talk me through, how important that is to see or have a therapist that kind of understands how an athlete should move, that you feel trustworthy enough to say, okay, I trust, my PT enough to say like, okay, I feel ready for that athlete to start that progression.
Right. Yeah. I mean, I use that objective data just as another piece of the puzzle, but people can kind of cheat the test, or they don't do as well because their other leg got stronger, or whatever it might be. So I think there is so much of that personal aspect of it and that one-on-one. And that's why anytime I have an athlete and I see that they're coming in for kind of that 9 to 10 month, recheck, which is usually that return to sport talk, I try to have even more than just an email conversation, like a direct phone conversation, like, okay, where are they at? What have we done? Like, I want to kind of go in the room and kind of know, okay, what's the plan? Sure. Just as much as the patient kind of wants to know the plan. Right. And so I think that's where, to me, yeah, I'm part of the decision, but I think I'm only part of the decision. I think the therapist really is a strong, advocate for the patient, whether we hold them back or we push them forward. Yep. And I think it's really important for me to have trust in the therapist and what they've been doing and having that conversation.
Yeah.
And, certainly I see patients who do choose to do their therapy not with us and maybe with a therapist who I don't know. And I do feel like there is a disconnect because the patient tells me, well, they told me I'm doing well and I'm ready to go. And it's like, I want to believe you, but I want more information here. I want to hear from somebody else too. So I think it's just so important to have that conversation. I just don't think you can reasonably clear an athlete fully without the full endorsement of the therapist.
From a surgical standpoint, talk me through how surgically, more so surgically than anything else, how we can, what are some advancements that you guys are seeing surgically or in that field that are making ACLs, maybe ACL re-tear rates lower, potentially not, or maybe the surgery's faster or more efficient. I'm curious about that side of things because, the ACL reconstruction 20 years ago is drastically different than today. So I'm curious kind of where you see that trajectory going of maybe, let's say 10, 15 years from now, what that might look like from an OR or medical standpoint.
Yeah. I think one of the biggest changes in the last 10, maybe 20 years is the different drilling techniques that we've started to explore. So now it's a much more anatomic ACL. Yep. So we're drilling those tunnels exactly where they should be anatomically. It used to be, you do that tibial tunnel and then you drill your femur through the tibia, the transtibial tunnel. You couldn't get your femoral tunnel anatomic by doing that, or it was really hard to do. So, that's been a big advancement, is just this more sort of anatomic reconstruction. But that being said, that's been now around for a long time, and re-tear rates are still what they are. Yep. And so I think, the next sort of then level is recognizing the meniscus pathology and recognizing root tears and repairing those, recognizing, ramp lesions and how that may affect and provide support to the ACL. And then I think the newest thing is the LET, or the lateral extra-articular tenodesis. So, the surgery itself has been around for a long period of time, but there's definitely a lot of new excitement about how that adjunctive procedure can add to the stability of the knee. The concept there is you're adding to the rotational stability of the knee and kind of just giving a backup support for that ACL. Yep. And so I think we're going to see how that affects the re-tear rates. Of course, we've, the quadriceps graft has kind of come onto the scene pretty hot and heavy. And sure, I think we're seeing that, that's not dramatically dropping the re-tear rates. And I think what we're going to see over time is that I don't think there's going to be one big thing that we're going to dramatically change that's going to drop it down all of a sudden. I think it's just, we're going 0.1% and 1%. And it's just going to take time to really keep chipping that down. And I think it's just going to be small increments over time. And, from a technology standpoint, our grafts are strong, our fixation's strong, our sutures are strong. I don't think that's where the advancement's going to be necessarily. I think it's going to be more, what are the things we need to sort of recognize of who's the at-risk patient and why, and what else do we need to address other than just their ACL or fix just what's torn? Do we need to do an LET? Do we need to do something else to support that ACL.
Anything else you want to add to the conversation that you may have, simple or, anything like that you kind of want the audience to kind of know from a surgical side of things?
Yeah. I think it's something where I think you want to have a therapist and a surgeon and a team that works together. So if you're a therapist, find a surgeon you work well with. And if you're a surgeon, find some good therapists that you work well with. And if you're a patient, look for a physician and a therapist and a team that works cohesively and does this routinely so that you can have that good, clear communication. You know what to expect. Everybody's on the same page. There's just no confusion. It gets more streamlined and it's safer that way. So, I think it's just, email, cell phone, popping up in the clinic, just be available, whether you're the therapist or the surgeon. And if you're the patient, reach out when you got questions, just communicate.
Thanks for watching. If you're a physical therapist or other medical professional looking to elevate your ACL rehab practice, visit tornuniversity.com and book a one-on-one consultation where you can speak with me directly about any specific challenges you may face and fine-tune your approach to ACLs. Also be sure to check out my monthly webinar series where I dive deeper into ACL-related topics designed and shaped by your specific needs and questions. Don't forget to like, subscribe, hit that notification button for more content, interviews, and more. Follow me on social media at Torn University for more daily ACL related topics. And as always, drop any comments or questions you may have about ACLs, and I'll catch you guys in the next video.